Thank you for joining me for this talk entitled, The Science of Obesity, Where Might This Lead Clinical Practice? I'm Dr. Sean Wharton. I'm an adjunct professor at McMaster University and York University and the medical director of the Wharton Medical Clinic. Obesity is a pandemic. It affects between 650 million to 1 billion people across the globe and 9 million Canadians. Excess adipose tissue causes or exacerbates multiple medical conditions, including diabetes, cancer, and COVID-19. This morbidity and mortality is primarily due to the dysfunctional white adipose tissue causing inflammation. This can affect almost every system in the body. So how good are we at treating it? Unfortunately, we've not been very effective for a long time, and only recently are we getting a bit better. This Canadian study looked at lifestyle management, a healthy diet and activity prior to the advent of effective treatments. We found 7 patterns of weight loss. Let's focus on the purple and yellow lines, which represented weight stability or minimal amounts of weight loss of only 2.3%. This made up 2/3 of the patients. So most patients cannot achieve significant weight loss with just lifestyle interventions. But do we need greater weight loss? Sure we do. Let's look at the improvements we get in medical conditions with weight loss. We get some diabetes prevention at 3%, but more at 10% weight loss. Many conditions need up to 15%, such as diabetes remission. So more weight loss is better. Our challenge in terms of getting greater weight loss is our lack of understanding of the complicated science of obesity. The pathogenesis involves biological, genetic, psychological, and environmental factors. Body weight is meticulously regulated by the brain, an organ we barely understand at the best of times. The science of energy homeostasis is rooted in our genes. If our genes drive up even a small surplus of calories, less than 1%, that can easily result in elevated BMIs. Unfortunately, once that weight is there, biological defense mechanisms kick in and keep the weight elevated. The gut-brain connection plays a major role here. Hormones such as GLP-1, PYY, leptin, and ghrelin are all generated from the gut, and then they head up to the brain. And if they are dysregulated, either not enough of them or too much, this can lead to elevated weight. So what does this science lead us to conclude about obesity? This slide is likely the most important slide in my slide deck. The science tells us that obesity is not caused by overeating, but that instead, overeating is caused by obesity. This is not just a play on words. It has been shown in many studies that overeating cannot cause obesity if you do not have the neurochemical and genetic profile to develop this elevated weight. On the other hand, if you have genetic and biochemical setup for obesity, this leads to hunger, cravings, and overeating, leading to elevated weight and to obesity. Our current understanding of the brain and the gut hormones have helped us design treatments that actually work: psychological intervention, pharmacotherapy, and bariatric surgery. Based on this science, there are now options for pharmacotherapy. We have some medications approved in Canada and some emerging medications. Liraglutide was the first effective weight management medication to come to Canada in 2015. For the first time, patients got some relief from their obesity with this daily injection. They got up to 9% weight loss in the completers. The primary side effects were nausea, impacting up to 40% of patients. This was both tolerable and also a transient side effect. We did a real-world study looking at liraglutide and got promising results, up to 7% weight loss. We also saw nausea as a side effect, but we also noted that constipation was a major challenge for many of our patients. The second effective drug to hit Canada was the combination naltrexone and bupropion in 2018, again impacting the brain. Overall, we're seeing about an 8% weight loss here and improvements in cravings, which can be a real problem for many patients. The main side effect was, again, nausea. This medication cannot be used in patients who have a seizure disorder or those on opioids. So far, the two medications that we have in Canada have not pushed past that 10% weight loss mark. Emerging medications include semaglutide 2.4 milligrams, a once-weekly GLP-1 analog as seen in this recent trial. Here, we finally cracked the 10% average weight loss range, getting to almost 15% weight loss with semaglutide 2.4 milligrams. Most impressive was that 1/3 of patients had greater than 20% weight loss. We've never seen that kind of result in a non-surgical trial. The most common side effect was again nausea, similar to that seen in other semaglutide trials. Another emerging medication is amylin, again targeting the brain, decreasing appetite and increasing the feeling of fullness. The monotherapy trial here shows 10.8% weight loss, but the compelling studies are looking at amylin combined with a GLP-1, and this phase 2 trial showed a promising 17% weight loss. Early days, but still very promising. Nausea and GI upset were again the main side effect. The newest emerging medication is the molecule Terzepatite, a dual agonist of GIP and GLP-1, treating both diabetes and also weight. Most of the clinical trials with Terzepatite are in patients with diabetes. The studies represented here in blue. But weight management trials in patients with and without diabetes, seen here in purple, are also pending. So what can we expect from Terzepatite? In patients with diabetes, this phase 2 trial showed 11% weight loss. We know that patients with diabetes lose less weight than those without diabetes, likely due to metabolic adaptation, a phenomenon we have yet to understand. Therefore, we can expect even greater weight loss with this molecule in patients without diabetes. The main side effect of Terzepatide was again nausea and also some GI side effects. In conclusion, the science of obesity is complex and is driven by the brain neurochemistry that interplays with genetics and the environment. The gut-brain connection is the main target of many new effective treatments. Overall, treatments for obesity are still in the limited stage, but increasing in a rapid manner as we gain more scientific knowledge about this condition. Thank you very much for your time.